All right, so today we have Dr. Essie. She's and I can say her last name, Magenta. I think I'm pretty close. A friend of ours. She spoke on this before on our Echo, so it's been a little while, and we're happy to have her back. I actually saw her give this talk a week ago, so I thought, well, Dr. Cole Perringer was unable today to give the talk, and so we asked Dr. Essie, and she graciously accepted, and we can't be more thankful. So. Nice talk on burning topics in addiction medicine, so it's going to be fun.
We have some great talks coming up on our Echo. November 27th, Haley Hillstrom and Troy Green from HIDA are going to be updating us on some public health and trending drugs. And then Rick Moldenauer is going to be talking about some methadone overview items. And then a reminder, on the 25th of December, we will not be having Echo. So you can't log in and join us for Christmas dinner that day if you celebrate Christmas, because we won't be there.
Yeah, go ahead and show up, but we won't be on.
Yep. Other echoes to check out are listed on the bottom of the screen if you're interested in more topics and getting more CME.
All right, so remember there is CME, but when Katie sends you that little thing, make sure that you fill out the questionnaire and you get one free CME. So please do that. Remember that Dr. Essie would love to see your beaming face today, so feel free to turn on your video so that she is talking to people and not boxes. So that would be great.
Just remember, we are always here to help. If you have any questions about policy, protocol, patient scenarios, pretty much anything, our contact information is listed below.
All right, and remember, you go on the Center for Opioid Resource and Education. The core site has lots of different things that you might want to implement into your clinic. A lot of different forms that you can use or change or do whatever you want with them. So feel free to check that out. And with that, we are going to move to Dr. Agenta. Now, do you want to share your own screen?
I could share my own screen.
It's either that or you got to tell Katie when to, when to
Oh,
switch.
let's try this. Share desktop one.
Your slides are so pretty. They look so
Oh,
sweet.
thank you. Oh, that's not.
You've never said that to me, Aaron.
I know. They just don't look like hers. Hers look like a warm hug with all the colors.
Must be our new medical student that's in the background, Alex. Ah, there he is.
Okay.
I hope he learned something from you, right?
I don't know. Yeah, no, I'm excited. It's gonna be good.
Document screen.
What do you think? Do you want Katie to share them, or do you think you got it? I'm not going to say a thing because I'm
asking
bad.
me for privacy settings. Okay, sorry. I'm gonna have you share it because I'm not
Okay.
at home. I took my laptop thinking that everything was all set.
No big deal. Katie will throw them up, and then you just tell her when to switch them.
Okay. All right, thank you. So I'm happy to be here. It's Essay Agenta. And so I was here before talking about food addiction. So today we're going to be talking about cannabis and nicotine. And I know Dr. Reznikov gave some talk about cannabis in older adults some months ago. So it's a similar thing with the cannabis part. And so next slide. I have no financial relationships, and we're going to be talking about the use of cannabis amongst older adults, talk about the history of mentholated cigarettes in the Black community, the history and progress. And now we're talking as a medical community, there are more and more papers coming out about using vaping as harm reduction. So we'll revisit vaping. We'll talk about its use in adolescence and also as harm reduction, and then visit some old meds and some new medications. And so just a reminder, cannabis plant has over 100 chemicals. The two most studied are THC and CBD. And THC, or 9 tetrahydrocannabinol, is the psychoactive component. And what's in the name? We've used marijuana for centuries, but at some point there was some stigmatization with the word marijuana. So now the medical community is using cannabis more, especially in their studies and presentations. You'll hear me say cannabis. And so our first talk today. So this is a patient, 74-year-old, a patient I admitted on service. So I was inpatient. She has had a history of insomnia. It's been driving her crazy. She's had a sleep study. She sees her PCP pretty regularly. She's on esozopiclone, 1 milligram at bedtime. It's still not really helping. So she tried a gummy. Next slide. She tried a gummy and she was like, oh, wow, this is really helping. And she started to get gummies online. Her family didn't know the extent to which she had been using. We can do the next slide. Her family didn't know how much she had been getting, and she had been falling. Family noticed she was more foggy than usual. The day she presented in the hospital, she got agitated and was hallucinating. Her daughter got so worried and called the ambulance and thought she was having a stroke. And so initially she said, I only take about 1 a day. And then later was like, well, maybe it's like more like 4. And eventually she was like, sometimes I lose track. I could take as much as 8 a day. And looking at she brought the packet in, and it was about 5 milligram THCs each gummy. And so imagine taking 8 of those in a day. And so she was falling more frequently, foggy. So we discharged her. She did better. I discharged her. So imagine her coming to you in the clinic and being like, hey, can I try again? Like, if I'm really, really good and I take only 1 and it helps with my sleep, can I try taking a few gummies? So those are part of the things that we'll talk about today. How would you counsel this patient? Next slide. And so some of the things that we'll think about, some people will say, I'm not a certifier. Why do I have to talk to my patients about cannabis? But if you're not talking to we have a duty to know more about it, to talk more about it, but also people are getting information online and from the dispensary. And so we should know at least, how does it affect us? How does it affect our sleep? Is it causing any psychotic symptoms? What is an older adult should we be worried about? How should we counsel each patient? And so the answer for this question is that tolerance may occur with frequent use. So the more you use, the more you're going to need to keep upping that dose to get the same effect. And we'll talk more about the effect of cannabis on sleep latency. So what is we're talking about it, how significant is the use? So this is a study out of Michigan that was published in 2023, looking at adults aged 50 to 80 years. And they saw about 1 in 8 adults in the United States is using cannabis. And in adults who have higher rates of risky drinking with alcohol, those adults are 8 times more likely to use cannabis. So they're using both alcohol and cannabis. So that combination is not a great one. So older adults, higher risk of falls, higher risk of cognitive issues, add on psychoactive medications. So we're doubling those risks. And so that's at least one thing to talk to patients about. Are you using with anything else? Next slide. And so cannabis use amongst older adults has increased. The highest rate of use is in youth, so 18 to 25 years, but that has stayed steady over the years. But in older adults, we've seen it go from as low as 0.4% in 2006, we're getting up to 5%. And that's the highest rate of rise in any one age group. And it's multifactorial, right? Decreased stigmatization, We're having increased access, increased legalization. And these are also, we talk about baby boomers who used when they were younger. And so now as they get older, it's like, oh, I'm familiar with this. It doesn't cause as much harm. Everybody in my community is using it, so maybe I can try it as well. But one thing to note too is that you can go on. One thing to note too is that the potency is increasing. So we used to have potency of about 5%. We're seeing as high as 99%. And with that increase in potency, we are having increase in the side effects. And so why are our patients using it? There are good studies with the effect of cannabis on neuropathic pain, in spasticity, so like multiple sclerosis, Parkinson's disease, we have good evidence. In nausea and vomiting, especially with oncology patients with chemotherapy. But there are other uses. Chronic pain is probably going to be the number one reason older adults are using it, chronic pain and sleep. But the evidence is not that great. And we'll look at that a little bit. But we're also using it recreationally, and people are also tired of all the medications, pharmaceuticals that they're taking. And it's like, well, if I have a natural substance, why wouldn't I just use that? But then one of the questions we should be asking, because it's a plant or an herb, does that mean it's safe? And so as we are seeing older adults use cannabis more, we're also seeing higher rates of side effects. We're getting more studies now. So cannabis is still a Schedule I medication. That means that we can't really do randomized controlled trials, especially with the cannabis plant. Some of these studies are being done with like Marinol, Namoximol, so with synthetic cannabis. And so, but now we're seeing non-randomized controlled trials because we're having more and more people using cannabis. And so they're reporting mixed reports in terms of chronic pain. Some studies say, oh, yes, it's great. Other studies like, it's not that great. And the RCT, so the randomized controlled trials, are reporting more negative side effects than the non-randomized controlled trial. So we still need to study it more. We're seeing higher frequencies of adverse effects. Next slide. We're also seeing higher number of ED visits in the United States, in Canada. This we saw in Colorado when Colorado was the first state that legalized cannabis, and they saw higher rates of ER visits even in children who mistakenly took the gummies because they look like candy. And in older adults, we're seeing this rise post-legalization. And so like we said, with the rising use, we're seeing more side effects. So pulmonary side effects, especially if you smoke it, so combustible. If you smoke it, our patients with COPD and asthma are reporting higher rates of pulmonary side effects. We'll talk about cardiovascular side effects and drug-drug interactions. We're also seeing increased cognitive issues, temporary psychosis, but also increased risk of development, especially in our younger patients, right? Increased risk in development of chronic psychotic disorders. And then the question always arises, is it someone who was predisposed to schizophrenia already and the cannabis tipped them over, or is it a risk factor on its own? We're still yet to know. And there are increased rates of cannabis hyperemesis syndrome. We're seeing cannabis use disorder. It's a real thing. So the cannabis use disorder, the question to always ask, in your mind, even without going through the criteria, is how much is the cannabis use affecting this individual? So continued use despite risk or despite harm. Next slide. And so looking in the lab and in our patients, we're seeing increased risk of cardiovascular side effects. So cannabis has stimulant effects. So it raises the heart rate, right? It constricts the heart. So in an older adult, the concern is this is someone who's probably already has high blood pressure, probably already is at risk of heart disease. Add on to that cannabis and vasoconstriction, you're decreasing the supply of blood to the heart. You're increasing myocardial stress. Also think about peripheral vasodilation. So almost like I remember Dr. Reznikov talking about a warm bath. Heart rate is increased, but when you get up because of the peripheral vasodilation, get dizzy and almost pass out. And the last two effects are seen when it's smoked. So when cannabis is smoked, there's increased risk of cannabis being possibly thrombogenic. And so at some point, you know, as time has gone on, now we're realizing that, oh, okay, cannabis can increase the risk of myocardial infarction. Cannabis can increase the risk of cardiac side effects, especially we're seeing higher rates of cardiac events post-operatively in patients who smoked before surgery. And our patients with atrial fibrillation, we're seeing increased risk of atrial fibrillation with heavy cannabis use. Next slide. And so this study was published in the Journal of American Heart Association earlier this year. There was a lot of talk about it. It was an observational study. They did call people up on the phone, try to figure out how much cannabis they were using and if they had ever had heart disease. So there are some issues with the study, but that is one of the best information we have right now. And they compared the risk of heart disease, myocardial infarction, strokes in patients using cannabis. And they found this was true regardless of whether individuals had ever smoked cigarettes. And the cannabis use was, the question was, do you use cannabis? They didn't differentiate between, are you smoking cannabis? Are you using an edible? And they found that in people with higher rates of use of cannabis, they also had higher rates of heart disease, myocardial infarction, stroke, and composite infection of all three diseases. Next slide. And drug-drug interactions, also very important in the older population. These are patients on several meds. Thinking again about our patients with atrial fibrillation, patients on digoxin and warfarin, especially the component of CBD, we find higher rates of drug-drug interactions with CBD. And being psychoactive, patients on psychoactive medications, like the case I presented, one of the first things I told that patient is, hey, you're on esozopiclone, add cannabis onto that, I worry about your increase in falls. I worry about your increase of sedation, hallucination. And so those are some of the risks that I talked to her about. Of course, for her, she's not a good candidate for cannabis. And I did let her know that. But I said, these are also the reasons why I think that. So not just the blanket no, but this and this and this are the reasons that I think that your risk is higher if you keep using this. Next slide. So sleep, so chronic pain being the most common, sleep probably the next most common. Cannabis does help with sleep. It helps people fall asleep. So it decreases the latency, which is the time to fall asleep. It suppresses nightmares. So a lot of my patients with PTSD saying, hey, don't talk to me about cannabis, talk to me about my meth use or how to quit other substances other than cannabis. I feel like this is the only substance helping me. But what is the quality of sleep like? It's not that great with cannabis. And if patients stop it, rebound insomnia can be worse. It can be really problematic for patients. Next slide. So, like for each patient, assessing that risk, especially we have patients who say, I had a patient tell their psychologist, I feel stigmatized because every time I have a visit with you, this was your fellowship. Every time I have a visit with you, you talk about my cannabis. I am not concerned about my cannabis use. So in those patients, you want to at least be able to say, this is your risk, these are your risk factors, these are the things that I'm worried about. If you were to use it, these are the ways that possibly these are the safest ways that you should use it. Assess the fall risk, assess their comorbidities. Next slide. Find out why they are using it in the first place. And so co-use of alcohol and cannabis is high. Co-use of cannabis and tobacco is also on the rise. And we'll talk a little more about that. But trying to provide a judgment-free environment to say, hey, because many people are not telling their doctors, especially older adults, you don't want to be judged for possibly using cannabis, but at least being open to where they can trust you enough to say, hey, I am using it. This is how much I'm using. This is what I'm using. Because a lot of times we don't even know what is this, where are they getting it from? How are they obtaining it? Is it only cannabis in the product? If someone is vaping, you say, what exactly are you vaping? Are you vaping just tobacco? Are you vaping cannabis? If there's one thing you take from this talk, it is start low and go slow. Because we talk about dose stacking. Some patients, especially with edibles, because when you take an edible, the effect is not as fast as smoking. So someone takes an edible and they're like, this is not working. Let me take another one. Probably not working. Let me take another one. And then 4 hours or so later, they may end up in your ER. Okay, so we can pivot to mentholated cigarettes in the Black community. First of all, I want to say cigarette smoking is still the leading cause of preventable death, disease, and disability. It shortens people's life by about 7 to 10 years. We as a body, American Society of Addiction Medicine, ASAM, initially, this was one of their big topics years and years ago in the history of ASAM, but the opioid epidemic overtook everything else. And so we've kind of pushed it to the background, being like, hey, I'll help you with your methamphetamine, heroin, fentanyl, but you can keep smoking, especially in treatment centers. I've seen one of the addiction psychiatrists would say, I will save you from your alcohol, but then you will probably get killed by your tobacco use. So it's something that the Addiction Medicine Society is starting to think about again, about bringing to the forefront. And so we should not lose hope in trying to have patients quit using cigarettes, quit smoking tobacco. Next slide. And so this is a patient, she's 69, she was a Black female, she's being diagnosed with lung cancer, and she still cannot quit. She smoked 1 pack of cigarettes per day for most of her adult life. She smoked mentholated cigarettes. And in the Black community, even in my community, when I go to the African store, I never realized how much advertisements about mentholated cigarettes there are, even in the grocery store, until I started researching this and started one day just looked up and I was like, oh, it's right there, and so even young kids are seeing this. You see people in your community smoking mentholated cigarettes. And so there are now more anti-tobacco activists in the tobacco community. And so she's hearing talk about some of them recommending vaping as opposed to use of mentholated cigarettes. And she asked, what is your opinion on transitioning to vaping? So we'll be addressing those. Next slide. So as far back as the 1960s, so what is the big deal about menthol in tobacco? It's a flavor. It's mint. It cools the effect of smoking cigarettes. So people are more likely to start using. They're more likely to take deeper inhalation, so deeper puffs, and it's harder to quit. It feels good, But all other flavorings have been banned. Years ago, all other flavorings in cigarettes were banned, but not menthol. And why is this? Next slide. As far back as the 1960s, tobacco companies were laws were passed where they could not advertise to the youth. And so they pivoted that advertising to the Black community. In the 1960s, there were about 10% of use of cigarettes in the Black community, but now of mentholated cigarettes, it's now up to 85% versus 29% in white smokers. And they spent a lot of money on ad campaigns, for instance, in Ebony magazine or other magazines that more likely to be used by the Black community. They sponsored jazz festivals, so festivals in the Black community. And there are even studies showing that in young kids, because of the advertising in the Black community, when they've done studies in young kids saying, hey, which cigarettes are people like older adults or so more likely to smoke in your community, they can name those mentholated cigarettes. Next slide. And so in 2021, the FDA said, okay, it's time to ban mentholated cigarettes. It could save over 500,000 lives. There's a lot of support. You would think it would be easy to pass the law. No, it's not easy. This year, there was an update, and pretty much, especially being an election year, they said, no, we're not going to approve this right now. We're going to put this on pause. And part of that has to do with Black leaders. It is such a political topic. If you ban menthol, are you targeting the Black community? Some people say there's a higher chance of stigmatization. We talk about deaths in males selling singles on the street. And so they worry that with something becoming illegal, if a Black individual is carrying mentholated cigarettes, are police more likely to arrest that person because of that? So it's a pretty charged topic. And so most administrations try to stay away from it. And most Black activists actually favor not banning, or not most, but there are some Black leaders or leaders in the Black community who say, hey, we should not ban this. And you even see anti-tobacco activists now promoting vaping. Next slide. And so now we're pivoting to vaping. So tobacco, so many species of plants, and the plants are grown for their leaves. The leaves contain nicotine as well as several other chemicals, but nicotine is the psychoactive component. It's nicotine that people are trying to get to. But it's to get to nicotine, tobacco is used in so many different ways. So we talk about cigarettes and cigars, the pipe, chewing tobacco in a bid to get nicotine. Next slide. But when in combustible cigarettes, in the tobacco smoke, there's so many compounds, some of which are carcinogenic. And so we have known over the years, there were years that it was said that, oh, smoking is good. People were smoking in the hospitals, people were smoking on airplanes. You were giving gifts of cigarettes, right? And then more and more studies came out until the first Surgeon General's report. And even after that, it took so much more years to try to decrease the rates of combustible cigarette use. So it is on the decline. Next slide. It is on the decline in older adults and in youth. But as in the youth, vaping is much more common. That now with campaign, I think this is the first year we're starting to see decrease in rates of vaping use in the youth, in adolescents. Most of the vaping is flavored e-cigarettes. So e-cigarettes or vapes are flavored. 9 out of 10 people are going to use flavored e-cigarettes. And the flavors are not cigarette flavors. We're talking candy flavors. We're talking fruit flavors, things to get people, especially younger age group, middle school, high school. This is they're more likely to use vapes first than to smoke cigarettes. And so they're also more likely to transition to cigarettes at some point. So what we'll talk about dual use. Next slide. And so nicotine acts on nicotine receptors. It has stimulant-like effects. It's pretty much like any other substance of abuse where it increases dopamine in the brain's reward. So you smoke it, it feels good, or you use it, it feels good, you want to use more of it. And especially when you start using it, it increases maybe concentration, alertness, arousal, that feeling of reward. Next slide. And as people smoke it more, as people use nicotine more, they realize that, okay, I have to keep using more to feel good. So it starts to seem like it's helping with negative states. It's helping with mood. It's helping with irritability. But what is really happening is that the more you use, you're starting to alleviate withdrawal symptoms. And so it's a vicious cycle. Initially, you start using more just to help with withdrawal symptoms. So every time you smoke, you're like, oh, I feel great. So you'll keep smoking, and it's hard to quit smoking. Next slide. And so tobacco is often the first substance used. When it's smoked, or vaped even, it takes just a few seconds to get to the brain through the pulmonary pathway. And so that's part of the reinforcement. When you use any substance that triggers a reward pathway or gets to the brain quickly, then it increases the rate of reinforcement and dependence. Next slide. And so repeated use leads to more use. After 100 cigarettes, about 70% of people would develop a pattern. Next slide. So e-cigarettes basically are a device that has something that lights up the aerosol or that burns. So the aerosol is what people inhale. Next slide. And so it looks great, right? Vape pens are marketed towards adolescents or also young adults to feel cool, to make it look cool. Even this year, back to school, there was a highlighter vape pen. So back to school supplies. And some people will say, oh, when I was searching for school supplies, this popped up too. It's like a vape pen that looked like a highlighter. And so the US Surgeon General in 2018 said, hey, this is an epidemic and we need to try to do something to help youth to quit. We need to start doing more campaigns. Next slide. And so we'll be talking about harm reduction in adults, but I wanted to make sure that we're clear that nicotine is not good in young brains. It's harmful to developing brains. We've even seen, we're starting to realize that there are increased rates of depression and anxiety in youth that use it. And it's marketed as a stress relief, but it's actually worsening rates of depression and anxiety. And people are having withdrawal symptoms, which worsens depression, anxiety, irritability. And like we talked about earlier, we think that it helps with withdrawal symptoms, but it is actually the cause of withdrawal symptoms. And so that's something we call misattribution. Next slide. So can it be harm reduction, right? There's a Cochrane review that has been on for several years, and it was recently updated this year with a study showing that e-cigarettes seem to be more effective than nicotine replacement therapy or behavioral counseling, with decreased side effects from combustible cigarettes. And so Nancy Rigotti is highly regarded in the tobacco community, smoking cessation, harm reduction. And she recently wrote an editorial, February 2024, saying, hey, have we gotten to the tipping point of e-cigarettes? Should we as providers start to counsel patients to say, hey, you have tried to quit so many times and it's not working out. Maybe you should pivot to vaping since the harms appear to be less. So she's on the side of the addiction community that says, hey, this is harm reduction. We should be recommending it. But there's also a strong side saying, yeah, we don't have enough data yet. We should not be recommending it. We haven't had data, especially about the long-term effects. Next slide. There was a huge study earlier this year published in New England Journal of Medicine that compared e-cigarettes to standard of care behavioral counseling. They looked at what were the outcomes at 6 months. And they found that and they measured the biochemical cotinine in urine to actually see if people were smoking. And so in people who were vaping, about 29% of them absolutely stopped smoking, compared to 16% in those patients who received behavioral counseling. So they also noticed fewer respiratory symptoms in the group who were only vaping. And so that study is still ongoing. They're going to bring out more data when it gets to 5 years. They're trying to get to 5 years of studying. Next slide. And so also recently there was an observational study. So this is more from the side of the addiction community saying, hey, put a pause on, maybe we shouldn't be recommending it. There had never been really a comparison of what are the side effects. So they looked at cardiovascular disease, stroke, and metabolic dysfunction in individuals using e-cigarettes versus cigarettes. For pulmonary effects, they found that there were decreased rates of asthma and COPD and even oral disease. But one of the most concerning things they identified in the study was dual users. So people who vape are more likely to use cigarettes as well. And the risk is not just 1 + 1. It's more like an exponential increase. And we're not sure. One of the theories is that, well, you have chemicals in when you're smoking tobacco in combustible cigarettes, and you also have chemicals in e-cigarettes. And maybe when you add both of those, that risk is exponential. And so that's the theory right now. But that's one of the concerns, is that when someone starts vaping, they're more likely to tell you that they are smoking as well, smoking cigarettes as well. Next slide. So for now, think about it as something in your toolkit. At least that's what that Dr. Rigotti's editorial said. Maybe we should think about this as something in our toolkit. But we have only about 10 years of data. Also letting, especially young smokers, saying, hey, we should get you off of vaping, cigarettes, combustible cigarette. We should get you off of those, and tell patients about the risk of dual use. And there's also increased risk in people who started vaping that they may transition to combustible cigarettes in the future. Next slide. Next slide. So vaping, right? So a lot of times when I ask patients, oh, you vape, or you say, have you quit smoking? And they're like, yeah, I quit smoking. And then you go on with the visit, and later somehow it comes up, oh, I vape now, and you totally miss that. And so even when asking about vaping, sometimes it's like, how do I ask about this? Do I ask, how much are you vaping? What are you vaping? There's so many types of devices. If they had their device, you can look it up. So at one point, they said, oh, one pod is about a pack of cigarettes, but you're having devices that provide even as much as 5,000 puffs. So more of the questions are about how is it affecting your life? Is it something that, are you vaping at work? Are you vaping first thing when you wake up? Are you vaping last thing when you go to bed? I had a patient who was supposed to get bariatric surgery, and she was trying her best to stop vaping. She was vaping everywhere. She had vape pens at work, and she's like, I'm trying so hard. So one of the things she started to do was try to get some vape pens without nicotine. So she interspersed she makes those at home. And so some days she would have nicotine, sometimes she would have pens without nicotine. Ask them about, are you vaping any other substances? How much are you spending on this? Just to try to figure out how much how much use they are having in a day and how it's affecting their lives. Next slide. And these are some quick resources. Truth Initiative is it's a great website. Lots of data on there, lots of evidence-based medicine, and there's a digital quit support called the X program that people can sign up for to help them quit. Next slide. So I wanted to briefly talk about medications for smoking cessation. Next slide. So we know that nicotine replacement therapy, bupropion, and varenicline are the FDA approved. Varenicline has great data. So does nicotine replacement therapy. But one of the things about varenicline, next slide, is side effects. You know, a lot of people complain of nausea, they complain of vivid dreams. Next slide. And so usually it's started as you have a startup pack, which they say, hey, start a week before you quit. Start at 0.5 a day for 3 days, go up to 0.5 twice daily. So you're starting at a low dose to try to see if they're tolerating the side effects. But there is a recent article, next slide. And so nicotine medications, we are probably not using it enough. And Dr. Resnikoff would always say that we're probably not using it enough. We can be using higher doses, but also have to remember insurance may not pay for higher doses. We could put on a patch, and they can also use a gum or a lozenge. They can combine it with bupropion. They can combine it with varenicline. And there are no drug-drug interactions. Next slide. Next slide. Baby duty. So varenicline was initially created as, stop after 12 weeks, but we can keep it. If it's helping the patient, we can keep going at least 3 to 6 months. And so this article, next slide, that we'll talk about says next slide, in patients who have tried to quit several times in the past, they've tried nicotine replacement therapy, or they've tried varenicline, and sometimes it may have even been successful, and then they stopped. Maybe we should consider using higher doses. So instead of starting at 0.5, we can start at 2 milligrams per day. And so they put individuals in a varenicline intervention group and in a nicotine replacement therapy, and did that for 6 weeks. And so some individuals quit smoking, but in those who did not, they put them back, re-randomized them to either continue what they were using before, increase varenicline to 3 milligrams, and increase nicotine replacement therapy to using 2 21 milligram patches in addition to lozenges. And they found increased the increased doses helped with increased abstinence rates. Next slide. Oh, so going back to that study, so they found increased rates of abstinence. Some individuals, the biggest thing was nausea. The biggest side effects, especially for varenicline, was nausea. But they felt that, this is something that we should consider using higher doses. Like we're saying, we're probably underdosing. Usually we say if someone's smoking a pack of cigarettes per day, that should be someone who should be on a 21 milligram per 24-hour patch. But now we're saying more and more addiction specialists are talking about using even 2 patches or using a 21 milligram patch as well as the gum as needed throughout the day to help with cravings. Because sometimes too, it's the oral habit. Because people be like, oh, the patch is great, but when I wake up and want to drink coffee, or when I wake up and go outside on the patio, I remember smoking. When I'm anxious, I remember smoking. And so that's where maybe the lozenge comes in to play or the gum comes into play. So just trying to find different other ways to substitute with the habits. And so there's it's not a new medication. It's actually a plant that has been used in Europe for years for smoking cessation. It's a generic plant. And so UK approved this for medical use earlier this year. They have completed phase 2 trials for cytosine. It's called cytosine. Phase 2 trials in the United States, but it's not yet FDA approved. The FDA is asking for safety data for up to 1 year. So we may be seeing, and that started May of this year. So we may start to hear more and more about cytosine in 2025 and 2026. And I think the manufacturer is working on the dosing and all of those other things, but just wanted us to know that, hey, there have been no new meds for almost 20 years for tobacco cessation, but this is something in the works. Next slide. And trials so far have shown, there have been studies out of Europe that have shown that it's more effective than placebo, and it may be as effective as varenicline, and likely more effective than nicotine replacement therapy. Next slide. Okay, that's my talk. Questions?
Aaron,
I learned so much. That was awesome.
Aaron, did you want to ask your question? It's in the chat.
Sure. I just know that THC beverages are gaining popularity. Have you had folks come in and disclose that they're drinking those in excess? And do they come with as much risk as edibles or smoking?
Not yet. I haven't, but I also haven't been asking because the first time I saw those, I think in the grocery store. So I was surprised. I was like, wait, what? But I think it's also, you're probably going to get much more sugar first, because I think it's still 5 to 10 milligram THC in there. So if they keep drinking and drinking and drinking, they have to drink more of those to still get higher concentrations, which they could probably get more in gummies or from smoking.
Okay. Essie, it's interesting that over the last few years, there's more and more of that over the age 60 people smoking marijuana. And there's also been a significant increase in use of Adderall in that age group. We see this all the time. And it's like, do you struggle like I do with this thought that you're using THC or any kind of cannabinoid, and it's worsening your cognition, and now you're wanting a stimulant?
Mm-hmm. Mm-hmm. So true.
Yeah, it's funny, and so often when people come in, they're using marijuana. It's like, well, I think I have ADHD. I said, well, before we start anything, maybe we should stop smoking the weed, and that's really hard for people to do. It is, as you know. So
I think what was so surprising to me was like the inflammatory components of it. You know, often THC is touted to be anti-inflammatory. So I mean, for me, that was like huge takeaways was all of the like blood things that can happen and causing possible inflammation. Just crazy.
Other questions? Anybody want to chat them in or just unmute?
Yeah, and thanks for the reference book. I'll look that up. Cannabis Pharmacy is a reference book that discusses chemistry, benefits, and risk, and proposed mechanisms in different disease states.
Yeah, I'm currently in pharmacy, and throughout school, because I did schooling in Georgia, we didn't really learn that much about it. So I was really looking for resources on it and how it can interact with other medications and conditions. And that was one that he routinely cites his sources and things like that as well, and within that book.
That's awesome. I also really liked it's called Chasing Life. There was a segment Sanjay Gupta did on having weed. So we called it weed, a senior moment. There were different parts to it. But it was also interesting to know, like in some states like Florida, they said like in over 55 communities, they actually bus them to cannabis farms or cannabis stores, to go purchase and talk to the dispensary. So it's just interesting to know what is happening around the country.
So are you suggesting that as a retirement activity then? Yes, no?
No, just tell you what's happening.
Are you seeing that like edibles are becoming much, much more popular than smoking marijuana because people know smoking isn't great for them?
I think so.
Okay.
And edibles are easily accessible. The cannabis smell, it's very distinct. I was in the mall the other day and in the stall next to me, and I was like, is there cannabis in this, and it was an older lady, very nice, but I was like, oh, I did smell that, so I'm sure some people don't want to carry that around too. They don't want everybody knowing that they're using it. So I think they're more likely, especially in older adults, even probably in the younger age group, to use gummies, especially now that in Minnesota that is accessible and available. They're more likely to walk in there and get edibles and buy them online too.
Now, one of my old partners, Dr. McClure, is on. He had just mentioned at the beginning of this that he had just listened to this podcast about marijuana. Did you want to make a couple comments, Dr. McClure?
Wasn't about marijuana. It's about controlled substances and the DEA. There's an agent that was doing a podcast and it's aimed at ketamine clinics. But if you have any Schedule 3s in your office, particularly if you're going to use some buprenorphine for inductions, the chance of the DEA auditing you now is 0. In 2016, they said that's a bad optics. We're not going to do that anymore.
Huh.
And if you're a ketamine provider, the chance of being audited is less than 0.1%.
Wow.
So the bottom line is just keep good records, do an inventory at least every year, and you're good to go. And even if you mess it up, your records are horrendous, they're going to get a letter and tell you how to do it right. So,
oh, interesting. Because it is kind of interesting because years ago, we always worried about the DEA coming and looking at
big time.
We were supposed to keep a list of everybody that we had on and the whole
Yep.
thing, and everybody was scared to death of that.
Yep.
Looks like it went away.
Yep. Went away in 2016. The director said, that's bad optics. We want people to get on this.
Wow.
We don't want to scare off our providers. So
Interesting. All right. Well, any other questions for Doctor?
It says, how can we think about approaching patients on medical cannabis? So one of the things to know about medical cannabis is that the diagnosis for which people are being prescribed cannabis are not necessarily, so they're not based really on evidence. It's more of I would say almost like a lobbying. Like, oh, this is great for pain. Let's put pain on there. Oh, people are reporting this is good for PTSD. Let's put PTSD on there. So those conditions for which people are certified may not really be based on highest quality evidence, but at the same time, they have been certified. But I know that Dr. Specka, who I trained with in fellowship, she'll always try to say, hey, these are your risks. You should really think about quitting it, especially in younger adults or adolescents, because of all the, it can decrease cognition, it can worsen mental health. And so if you're dealing with other mental health conditions, it's like, I can't recommend that this is actually good for your mental health. So I think still erring on the side of caution is probably best.
My experience has been that it's one of the hardest things to get people to stop. Is that kind of what you feel like?
Yes.
Yeah. It's
Yes.
even smoking's easier. Marijuana, no, this works for me,
Yes.
right?
And part of it too is I think the decreased stigmatization, because even now North Memorial is considering taking it off of our urine drug screen, because sometimes you see it and it's like, what do I say about this? Especially if there are other substances and that you want to talk about. So we're getting to that point too, like with tobacco, and it's like, I'm sure someone has talked to you about this, but trying to be conscious about it, and just we as providers should be still telling patients, hey, these are the risks, right? At least it's good to hear from us. They do respect our opinions. So we should still be letting them know this is the evidence.
Just one last thought. I think probably you do a lot of hospital medicine, and you at least get to really start the conversation because those people want to be on a patch, right?
Yes.
I mean, is that kind of your way in?
Yes. And I see a lot of people who say, hey, I have no cravings in the hospital. I have no cravings. And I'm like, well, you're in the hospital, you're very sick, but you'll go home and it's the little things. It's you walk in the door, you want to drink coffee, you want to open the car door. A patient actually told me I had to relearn how to drive because every time I would open the car door, I would think about lighting up a cigarette. So trying to walk them through the ways that they smoke is very helpful. Doing CBT with patients is very helpful to identify the triggers.
Wonderful. Well, we are at about time. Really appreciate you stepping in, Dr. Gente, and really appreciate your talk. A lot of people sending you little messages in the chat. So thank you again.
Thank you, everyone.
Yes, thank you. I learned a lot. When can you come back? Because that was great.
I will have another talk ready.
Thank you so much.
No
All right,
problem.
everybody.
Thanks a lot.
All right, take care, and thanks again,
Thank
Essie,
you.
and we will see you all in a couple of weeks.
Okay, see you. Bye.
All right.